Hello and welcome to Precision Signals. My guest today is Dr. James Gulley, a physician-scientist whose career has been deeply entwined with the evolution of immuno-oncology as both a scientific discipline and a clinical reality. As Chief of the Medical Oncology Service and Co-Director of the Center for Immuno-Oncology at the U.S. National Cancer Institute, Dr. Gulley has helped shape the translational and clinical architecture of immune-based cancer therapeutics. His work spans first-in-human clinical trials, mechanistic immunology, and institutional frameworks for how immune interventions are assessed, approved, and applied. Long before checkpoint inhibition became a clinical mainstay, Dr. Gulley was among a small cadre of investigators advancing immune-based therapies in an era of deep skepticism. He persisted across several years of biological complexity and clinical uncertainty, emerging with a systems-level perspective that connects T-cell activation kinetics with real-world clinical implementation. I've had the privilege of collaborating with Dr. Gulley across multiple domains over the past several years, from the early days of immunotherapy development to more recent efforts integrating AI into the fabric of clinical research. At each inflection point in oncology, Dr. Gulley has brought a distinctive perspective, one that bridges mechanistic insight with operational execution and scientific rigor with institutional change. Whether designing adaptive clinical trials or reimagining clinical evidence generation and real-time data capture through machine learning, his work consistently reflects a commitment to rethinking what translational and clinical research can be and what it should demand of us. In this conversation, we examine persistent challenges in immuno-oncology, the limits of predictive biomarkers, the mechanistic opacity of treatment resistance, and the structural inadequacies of our current clinical trial ecosystem. We discuss the need for new endpoints, new evidence hierarchies, and new ways of modeling patient heterogeneity, both biological and clinical. We also explore how emerging tools such as AI-enabled protocol generation, wearable-derived phenotyping, digital pathology, and EHR-integrated data flows are reshaping translational and clinical research infrastructure. Dr. Gulley shares lessons from his recent work using continuous physiological monitoring to detect CAR-T toxicity before it manifests clinically. Our conversation exposed deep institutional questions that the recent technological and scientific advances raise. How do we validate learning systems that evolve with the data? How do we assign trust in an ecosystem where traditional clinical roles and their economic models are rapidly shifting? And what does responsible innovation look like when the tools of scientific inquiry themselves are increasingly autonomous? Let's step into the conversation and trace the signal beneath the noise. Hi, Dr. Gulley. Welcome to Precision Signals.
Thank you.
So great to have you on the podcast. I've had the privilege of knowing you for several years, having been trained at NCI, and then later when I was at the FDA, had a chance to work with you on multiple projects. But for our audience, I'd like to start at the beginning, your journey into medicine and cancer research. What originally drew you to medicine? What led you specifically into oncology and cancer immunotherapy?
Yeah. So first of all, Sean, I want to say thank you for inviting me, and I'm really honored to be with you here today to chat. You know, as you mentioned, we worked together for many years, and I really want to just say that I respect your vision for a better future for cancer patients. So about 40 years ago, I was an undergraduate, and I did a 10-week stint in a research lab at Loma Linda University working on immunotherapy. So they were actually working on tumor immunology there. But I got a fascination with the immune system, this immune system that could tell between self and non-self. And I got to thinking, could this be used, this elegant, complex system, be used to help fight cancer? So I did my MD PhD there. I did my PhD in tumor immunology, focusing on antibodies at the time. Then I went on to Emory University for internal medicine, came to the NCI for fellowship. And then when I began my research at the NCI, I made the big but calculated gamble. I argued that despite all the prior setbacks of immunotherapy, that this could fundamentally reshape cancer therapy and provide the best chance for cancer cure in patients with advanced disease.
Very interesting. And you clearly made a fascinating career choice very early on, committing to immunotherapy where the field was still in its infancy, and there was a lot of skepticism at the time about immunomodulation in general, long before immune checkpoint inhibitors. What convinced you at that stage, Dr. Gulley, that the immune system could be harnessed against cancer with a type of specificity, especially now, given the fact that back then, again, there was a lot of skepticism?
Yeah, so great question. I think that what I found was that the immune system really did have this exquisite capability of detecting self versus non-self. And cancer cells have mutations, and they have The viral associated cancers can have xenoantigens. And just the complex tumor microenvironment suggested that maybe with these foreignness of these cancer cells, the immune system could be really fundamentally important here. And rather than introduce toxins, poisons into, basically that's what chemotherapy is, into patients that affect normal cells and cancer cells. What could we be a little bit more specific for the cancer by using the immune system that is in all of our bodies and has, been so important in fighting against things like viruses and bacteria? And could we utilize that immune system? It was a gamble, I will agree, and there had been a lot of speculation about in the 70s and 80s about monoclonal antibodies, and we're going to finally have the cure. And then
Hmm.
there was just a lot of negative trials after negative trials, um, but we eventually overcame that, and now antibodies are used in cancer therapy all the time, and including in immunotherapy.
Right. Absolutely. Clearly, immunotherapy is becoming embedded in the standard of care across multiple tumor types. And as uh, we just alluded to, there was a period of skepticism, and there was some risk taking involved in your venture into this territory. So, what were, Dr. Gulley, the key mechanistic insights that you believe enabled the transition from theory in the world of immuno-oncology to practice?
Yeah. So I think that there were several things that happened there. So first of all, when I started out doing bench research, and it was relatively straightforward. We could understand the mechanisms, we could understand the activity, but these were all in controlled systems. And the one thing that was interesting there is that even in these controlled systems, not all the mice responded the same. So you have the genetically identical mice given exactly the same treatment, and yet only some of the mice were cured from their cancer. Others would go on and die from their cancer. So there was clearly more to it than just finding the right target and the right approach. There's clearly more going on at the level of the tumor. And
Mhm.
so then I said, okay, well, this is early, interesting data. Let me take this into patients. And the complexity got even more because then you have tumor heterogeneity, you have the comorbidities of the patients, and you have different environmental influences for each of the patients. And so that became another barrier to look at. But I think all of this gave us a deeper understanding of what could go on. And there was a lot of the trial and error and figuring out what worked and what didn't. Um, some of it was empiric, but
Mhm.
others were based on rational conclusions from the preclinical data that we had and the theory that we understood from what we knew of at that time, the immune system.
Sure, it makes sense. And clearly, immune checkpoint inhibitors really demystified the role of immunomodulation in treating advanced malignancies. And we started with immunogenic malignancies like melanoma,
Yeah,
and now there are approved indications in solid tumors.
yeah,
What's been interesting to me, I was at the FDA when immune checkpoint inhibitors came to the scene. So I had a very unique vantage point into the science as it was evolving, including the urgency that everyone felt to optimize efficacy for patients. Because as you mentioned, there is a lot of heterogeneity in mice and in humans. Now we have a lot of biomarkers for immune checkpoint inhibitors. Some have been approved, such as PD-L1 positivity. There's been two tissue agnostic indications. First one was in 2017 with pembrolizumab in patients with any advanced malignancy that are MSI high. And then later we had tumor mutational burden. So there are all these different biomarkers, but it seems like no single biomarker tells the full story. How do you see that field evolving? Because we have these sort of fragmented pieces of perhaps a larger puzzle.
yeah. Great question. So I'd like to go back and talk a little bit more about the immune checkpoint inhibitors because I think that's really important to understand where we got to where we are now and how biomarkers play a role. So I had been doing immunotherapy research for cancer for about 25 years when in 2013, Science named immunotherapy as the breakthrough of the year. And why was that? Well, it turns out that there are cancers, as you mentioned, immunogenic cancers, that the immune system can recognize. The problem is when the immune system recognizes it, the T cells say, oh, there's a cancer, I'm going to go kill it. And it gets in there, it starts to make different proteins. One of those proteins is gamma interferon. This can call in other T cells, but it also affects the tumor cells. One of the things that happens is it causes an upregulation on the tumor cell of this marker called PD-L1. That PD-L1 sends a stop signal to the T cell. So all of a sudden you have this T cell, it's raring to go, can recognize the tumor, but it's told to stop. And this is a normal mechanism that we have in our body so that our T cells don't kill our normal cells. So it gets into the inflammation area of inflammation, the bacteria, and it just kills the fat bacteria, but doesn't kill the surrounding cells. But in cancer, that causes a problem. So that causes the T cells not to be able to do their job. Well, we've been able to basically put a bag over that stop sign and allow those T cells to work. We do that by either these antibodies that target either PD-1 or PD-L1 that make that stop sign invisible to the T cells so that they can go ahead and kill that tumor cell. And that's what caused a revolution in cancer therapy when you had this deep and rapid and durable responses in patients with advanced cancers. However, unfortunately, it was only about 20 to 30% of the patients.
Mm-hmm.
So what we're seeing now is that, and that was in certain tumors. What we're seeing now is that in select tumors, if you have the tumor mutation burden, if you have the PD-L1 staining, meaning that there are T cells in there likely that have been activated, and that's the footprint, if you will, of an activated immune response with the PD-L1 expression there, that those are the types of tumors that are more likely to respond. It doesn't guarantee a response, but it does suggest that those tumors are more likely to respond. I think the predictive markers for immunotherapy are really important. We don't have all of them identified yet, I don't believe. But I think even more important than the predictive markers are going to be these dynamic markers, these pharmacodynamic markers that are proteins that change in expression after you give the therapy, because that can really help you understand the biology of the process and potentially help you understand which agent to combine this with down the road.
One of the things that I haven't been quite able to wrap my mind around is the fact that, can we combine, for example, several different biomarkers, PD-L1 positivity plus tumor mutational burden, and have a much more predictive power in selecting the right patients. I don't know why we haven't moved in that direction. As you mentioned, combination therapies have entered the scene, and they're working for a number of patients with various tumor types, but they also, it seems like, increase the incidence of adverse events. So one has to, I suppose, tread cautiously. So you mentioned other biomarkers that are more related to biology of immunomodulation. So do you think instead of focusing on sort of my reductionist view of the milieu of biomarkers, a composite endpoint of, say, tumor mutational burden and PD-L1 positivity, it would pay more dividends if we focused on these biologically informative biomarkers or combination therapies?
I think that's a great question. What we've seen is that if you combine biomarkers in a composite biomarker panel, you can get better predictive power. Mm-hmm. So if there are transcriptional panels that are associated with immune response, there's PD-L1 expression, then there's tumor mutation burden. It turns out that each one of those individually is important, but if you add them all together, they're even more predictive. In addition, if there may be other proteomic markers, depending on the immunotherapy, that are also going to be important. It's fascinating what we can do. Mm-hmm. I think that we're going to be able to learn from things like spatial transcriptomics, as well as spatial proteomics, not only what markers are present, but also what cells they are near. So if one immune cell is near a tumor cell or a different type of immune cell, that may have different implications for the outcome of that particular therapy in that particular patient. And I think we're going to be learning a lot more about that. I think that these are expensive approaches, and we may be able to, down the road, extrapolate from much more simple approaches like H&E stains, what is present in terms of both the transcriptomics and the proteomics. And by using machine learning, we can potentially come up with the same type of information just using a simple H&E slide, which will be, again, something in the future. There's a number of groups working on doing this right now.
That's great. I'm so glad you mentioned machine learning and AI. We're going to put a pin in that because I know you've done remarkable work in that space as well. But going back to immuno-oncology, Dr. Gulley, you've also been a pioneer and uniquely persistent in the therapeutic vaccine space, a field that has weathered a lot of disappointments over the years. But now we're seeing renewed momentum with new technologies and platforms. What do you think is fundamentally different today compared to those earlier generations? Is it antigen selection, delivery platforms, or integration of vaccines with checkpoint inhibitors? What do you think is different today that has renewed interest in cancer vaccines?
Thanks so much for asking the question. I think that there are several things that are different. Number one, it's the target. So in the past, we were focusing rather on tumor-associated antigens that are expressed in normal tissue as well as in cancer tissue, but maybe overexpressed in cancer tissue. These are difficult for the immune system to be able to generate a high avidity T cell response against, because these are part of the normal immune system, and the body tends to eliminate all of those T cells that could recognize normal cells. Let me tell you a few stories about some of the cancer vaccines that we've been working on in the field. Now, first, I need to just give a caveat about vaccines. Most of us, when we think of vaccines, we think of flu shot or childhood vaccines. Those are preventive vaccines. Those are vaccines that can help prevent disease. However, most of what we're talking about in cancer, there are preventive vaccines for cancer, such as HPV, can prevent human papillomavirus infection or persistent infection, and that could prevent things like cervical cancer or head and neck cancer. But most of the vaccines that we use in cancer are therapeutic vaccines. Most of these are experimental. We're going to share a couple of examples of that. So this is once the disease is already there. And can you get your body's immune system retrained to attack that cancer? So 3 short stories. Number one is a melanoma vaccine. This is a vaccine that is personalized for each individual patient. And this was a study that came out a couple of years ago. They took patients who had high-risk melanoma, that is melanoma that is either stage 3 or 4 that had been resected, but is a high risk for coming back, and said, can we give standard therapy, which is an immune checkpoint inhibitor, PD-1 inhibitor, alone versus a group that got the PD-1 inhibitor with this vaccine that they tailored specifically for the mutations found in that patient's tumor. What they found was that they could basically double the relapse-free survival of those patients if they got the vaccine plus the PD-1 inhibitor versus the PD-1 inhibitor alone. So clearly, interesting results. There's an ongoing confirmatory study. I want to mention another vaccine that we did, a clinical trial that we did in patients with more advanced disease at the National Cancer Institute. This was published earlier this year in JAMA Oncology. This is a vaccine strategy where we give vaccine plus an immunocytokine that can further boost the activity of the vaccine, plus an immune checkpoint inhibitor that can act at the level of the tumor to allow those T cells to work. So it was single arm study only, but and the vaccine was actually targeted against HPV-16. So that's a specific virus that causes cervical cancer, head and neck cancer, et cetera. It is not the only virus that causes that, however. And so about half of the patients were HPV-16 positive, and another group of patients were HPV-16 negative. We got some really impressive results on this study, about 3 to 4 times the expected response rate in those HPV-16 positive patients. But interestingly, none of the patients that were not HPV-16 responded. So this suggests that the vaccine really can help steer the immune response. The appropriate vaccine can help steer the immune response. And because HPV-16, the E6 and is not found in normal tissue, the E6 and the E7 proteins, this is a good, what we call xenoantigen, that the body can easily tell the difference between self and non-self. So it's a strong antigen. The body doesn't eliminate T cells against this. So the third study I just want to mention briefly is a study of an agent that was just approved August 15, just a few weeks ago. So this is an agent that also targets HPV, but this time a different HPVs, HPV 6 and 11.
Hmm.
So these are two HPV vaccines that cause the normal warts that sometimes one gets, as well as genital warts. But interestingly, it causes a rare disease called recurrent respiratory papillomatosis. This is a very difficult to treat disease that often requires an ENT surgeon to go in there and just remove these carpets of tumors that can happen. And usually it affects in or around the voice box. And so a lot of times the patients have very limited voice volume. And what they did was they showed that by coming in with this vaccine after they had removed the tumors in these patients that had had at least 3 surgeries and up to 12 surgeries a year prior, the idea was, could vaccine prevent the tumors from regrowing? And in fact, there was a complete response in 50% of the patients. That is,
Wow.
50% of the patients didn't have any regrowth of their tumor for at least a year, and many of them are still ongoing several years later. This led to full FDA approval of this rather than accelerated approval 2 weeks ago. So, and I think that probably in the future, what you're going to see is vaccines being used at least as single agents early on in the disease, either in the prevention setting, but for therapeutic vaccines early on in the disease in patients that have minimal tumor burden.
Yeah, makes sense. So you believe that therapeutic vaccines as monotherapy would play a more dominant role in early stage setting versus in a metastatic setting where I'm assuming they need to be augmented with other immunomodulators.
Yes, and it remains to be seen where they're going to play a role in the advanced disease. But if they are going to play a role, I believe it will be in combination with other
Sure.
therapies. And as we saw with our trial in HPV-associated malignancies, they may be beneficial to help steer an immune response to the right targets.
Interesting. Dr. Gulley, is there a hierarchy of vaccine technologies? Uh,
So that's a great question. What we say is that no agent is safe and effective until the FDA says it's safe and effective. So, in general, all the vaccine platforms that have been tested have not shown significant safety issues with any of them.
mhm.
But they're and they can all generate immune responses. But is that enough to translate into clinical responses in patients with advanced disease? No, typically not. Um, However, we do see levels of immune responses that are different between different platforms. So, protein-based platforms haven't seemed to see the same level of immune responses as either mRNA-based vaccines or DNA-based vaccines or vector-based vaccines that have the DNA in them, or other strategies.
Hmm.
How you get them, whether it's the naked DNA versus the DNA inserted into a viral vector, sometimes in a viral vector is better because you have the adjuvant effect of the virus. The body sees all the danger signals caused by this viral vector that's pumping out this protein, and so it can be more effective potentially. But until we get substantial numbers of vaccines that are approved by the FDA, we won't have a clear understanding of which platform is effective. I think clearly the baseline is you have to generate an immune response. If you can't generate an immune response, then you won't generate anything else. But that's necessary, but not sufficient to lead to a clinical response.
Sure. And clinical response is obviously critical. We know that it correlates with improvement in how the patients are feeling and functioning, and also obviously overall survival. However, response to immunotherapies has been quite challenging
Yeah.
to characterize. Um, where do you think we should be focusing on if we want to get a better understanding of tumor dynamics in the context of immunotherapies? Because the RECIST criteria obviously seems to be very insufficient for immunotherapy, especially.
So, great question. Very important for the field. I think these dynamic markers, these pharmacodynamic markers, that those are the ones that change during therapy.
Hmm.
This adds another layer of complexity to the predictive biomarkers, but it also adds really a important opportunity to learn about the biological impact of the therapy and help decode what combination therapies we might want to use also can help us understand the resistance mechanisms and the response mechanisms. And I think that it's going to take us looking at approaches that really help us understand the tumor microenvironment, ideally with sequential biopsies, um, and then putting that into the context. So I don't think it's going to be enough just to do bulk RNA-seq or even single-cell RNA-seq. I think you need to have it in the tumor, in the context of where that immune cell is in relation to the tumor. And so that's why I think spatial technologies like spatial transcriptomics and spatial proteomics are going to be really important to unlock some of the clues that we're going to see on the biology of the impact of these therapies on the immune system, and then help us design better treatment strategies, whether that's combination approaches or just better agents that can target more than one thing. Often with these bispecifics or trispecifics,
Right.
we can get more things targeted.
Yeah, makes perfect sense. And it seems like we have a lot of opportunities in understanding the biology of immunotherapies from a much more spatially granular way that can give us clues about intermediate endpoints that could be more predictive than tumor response, for example, and earlier in the disease process than survival. Dr. Gulley, validating these endpoints clinically, especially, can be quite challenging. Whose responsibility do you think it is to focus on endpoint validation, something that, as you said, is so critical to cancer research and drug development, but individual companies and institutions do not have a clear path forward for validating these intermediate endpoints, despite the potential benefits to the entire community?
Very important question for the field. So I would say that there is a role for multiple stakeholders to come together over this. I think one of my roles I play is the president of SITC, the Society for Immunotherapy of Cancer. This is the largest professional society focused on immunotherapy for cancer. We have worked with industry, that's pharma, biotech, and others, to bringing in the FDA, bringing in academic stakeholders to understand what we need to do in the biomarker space. This is so critical for moving things forward. One of the things that we believe that's really going to help with is our goal of getting 100 new agents approved in the next decade. So we started this audacious goal last year, January of 2024, and we are well on our way to meeting that trajectory of getting the full 100
Wow.
new immunotherapy agents approved over this next decade. But if we don't understand the biology, if we don't understand what's going on in the tumor microenvironment, we're not going to get there. So this is absolutely critical for the field. And it's really going to take all of us working together and coming up with ideas and biomarkers. I would say, though, to validate that, that's going to take large data sets. It's going to take large agreement on what needs to be done by multiple stakeholders in the field. And that is going to be really important in the next decade as we move forward.
Right. Absolutely. And when you think about the emerging approaches for immunomodulation, what are some technologies and platforms that we should be paying attention to?
So, if I had my crystal ball here, I would look deeply into it. I think, though, that there's going to be two things that start to emerge. I think that there is going to be a better understanding of how to utilize cellular therapies. And this is going to include better engineering of these cellular therapies with conditional gating and with armoring, some of which we've already seen in clinical trials. But I think that we're going to learn how to use cell therapies for solid tumors better. I think that we're going to also see combination approaches that are driven by rational designs that are going to lead to better treatments for patients with advanced disease. But moving on beyond the patients with advanced disease, I think we're going to have new detection methods. So with some of these multi-cancer early detection tests, could we come in and have a very benign type of treatment that could be utilized in that disease setting and decrease the chance of these very early cancers from ever becoming clinically relevant? I think there's going to be a lot of um, interest in that area and a lot of research in that area that's going to lead to much better outcomes totally for patients because the if you ask the patient, would you rather have cancer and then have surgery and cure it, or would you rather never have cancer? They're going to always pick, I'd rather never have cancer. So
Right.
if we can go very early on and eliminate it before it even becomes a problem in this so-called interception
Right.
space, this would be something that I think we're going to be able to make big strides in the coming years as technology gets better for detection and as we find ways to better treat these earlier cancers without having to resort to things like chemotherapy or
Right.
surgery.
Very interesting. In the disease interception space, obviously, the challenge of intermediate biomarkers are even more pronounced. And I'm assuming that pre-competitive collaborative efforts are
Yes.
necessary in that space. Is that also something that you're focusing on at SITC?
Yeah. So, I think, yes, we are focusing on how we can work with people in the pre competitive space.
Hmm.
And are there opportunities for us to take data that maybe is from clinical trials that have already been completed and that has careful clinical annotation? And can we combine data sets to really learn more using large language models, using AI, but also just having sheer numbers to find what really makes sense, especially in rare diseases,
Hmm.
to pursue? And I think that, there are certainly groups out there that have done incredible work on bringing together people like Project Datasphere, where big companies that have said, we're going to give you our data. And now even the NCI has said, yes, we're going to give you our data too. And I think unsiloing that data, allowing it to be accessed by multiple different people, I think that is going to be the way that we really help address some of the pressing questions and challenges we have in the field.
Yeah, data sharing very important, and hopefully the anxieties that folks have will continue to be less and less a bottleneck because a lot of the fears that people had about data sharing, frankly, haven't come to fruition.
Right.
And it seems like the benefits far outweigh the risks. So we're all hoping and wishing for that the community pays more attention to this. And hopefully one day we can have access, for example, to the FDA's data, clinical trial data after approvals. The FDA obviously publishes all of their reviews, and putting the data out there is not a giant leap beyond that because the data is known quite well. And again, FDA does have all of its in-depth reviews online. So maybe think that for audience members that are listening and interested in data sharing, we can all put our minds together and work on.
So, that's a really good point and interesting. And um, I, I was always under the impression that the FDA had obligations to companies to not share that type of thing. But boy, if that could be shared, I think it'd be a wealth of information.
Yeah, no, I think that legal uncertainty may not be as large of a barrier as most people think. But I think I agree. Somebody needs to do a thorough and definitive legal assessment, and especially nowadays with the AI race, which is global. I think having access to data has implications beyond advancing science. We're hearing a lot from folks that it can be, in fact, a national security issue if we don't leverage our biomedical data assets appropriately. And NCI also has a lot of data, and the clinical center, especially, has a tremendous amount of data going back
Yeah,
several years. So, Dr. Gulley, are you tapping into those data sets for secondary research?
absolutely. So we have published recently some of that, not all in IO, but
Hmm.
we did an analysis, for instance, recently that we published on where our patients came from and their backgrounds, demographic data. That was actually really telling because we want to try and expand our recruitment. We want to understand who's coming and why, and we want to be able to get our clinical trials done more quickly. So that takes patience, and we have to understand where we're able to get the patients and where we're not. And so this was the first step in that. Um, this was looking at data over 15 years, and then we can kind of compared it to the SEER database and to the the database of other clinical trials. And I think we showed that um, there were opportunities for us to improve how we captured patients.
Hmm.
I think big data sets like this, like you said, our data goes back in our current data system for several decades, and we have in-depth, clinically annotated data, and that can really help us get good insights into what's going on with the patients. And in some cases, we also have the research data that is the immunotherapy research lab data associated with that, and we can go back and really understand the differences over time of the effects of the immunotherapy. And we do have a number of patients that are out many years from their initial immunotherapy and still have no evidence of disease, and then kind of looking at them and comparing them with the patients that didn't have as good a response. What do we make of it?
Yeah,
And so those are the types of things that are ongoing right now.
that's great. And for those that may not be familiar with the clinical center, it is really the holy grail of data because it's multimodal, from imaging to molecular profiling. Everything is essentially more or less in one building. And speaking of the clinical center, I think maybe beneficial, Dr. Gulley, if you could briefly talk about the clinical center because it's
Yeah.
something that I've noticed, frankly, that a lot of folks don't know about, and they don't know about the history of the clinical center. It's amazing academic and scientific output. Um, Innovations that have led to increasing our fundamental understanding of cancer biology and several first-in-class therapies that have emerged from the clinical center. Can you talk a little bit about how it's organized and what types of research the clinical center is optimized for doing?
Great question. So the NIH Clinical Center is a clinical center that is the place where all of the patients that are seen here at the NIH are seen either in the outpatient or inpatient settings. We have ICU. We have basically all of the um, departments that a regular hospital would have, except for the emergency department. We do not have an emergency department. We do have a triage area where we can see patients and decide whether or not they need to go to an inpatient setting or outpatient, and if inpatient, do they need to go to the ICU or not? I can tell you that of the 27 different institutes and centers that make up the NIH, um, the majority of them do have a clinical arm and in the intramural program. So there are roughly 17 different institutes or centers that have a clinical component, and all of their patients are seen here. The biggest of these is the National Cancer Institute. We have approximately 40% of the inpatients at the clinical center, and we have about the same proportion of outpatients too.
Hmm.
What I can tell you is that the type of patients that we typically see are patients that are studied by the investigators here, their disease area of interest or their modality area of interest. But often, because we can fly our patients here at no charge and treat them here at no charge, we do not charge a patient, do not charge insurance. We can get diseases that are very rare and are very difficult to treat elsewhere or to study elsewhere. And so things like this recurrent respiratory papillomatosis I was talking about, that is something that we can see here, treat here, and actually the trial that led to the approval of that vaccine was done entirely here at the NIH Clinical Center. A single center study, small number of patients, but a rare disease and a big benefit, and that led to the FDA approval. So rare patient populations we do well. Combinations that can't easily be done elsewhere, often novel combinations, or up to 4 different novel combinations from different companies. Those are difficult to do elsewhere. And also, we do some cancers like prostate cancer, which is a common cancer, and we just draw from the local area for that. So it just depends on the disease focus of the investigators at the NCI.
Sure. Yeah. No, the clinical center is certainly a magical place and a very intellectually fulfilling place. Again, I'm privileged to see a glimpse of it when I was at NCI. And one of the things that really stood out to me at the clinical center was the fact that there's a lot of camaraderie, there's a lot of collaboration, cross pollination, that not only optimizes the way one can take care of patients, but that cross pollination and multidisciplinary approach generates a lot of interesting new ideas and research questions. And that has, I believe, been one of the main pillars of the clinical center, where one can see across disciplinary lines. Do you believe, Dr. Gulley, that in general, in how we treat cancer patients, or in a way in medicine, that we've become too siloed and hyper specialized?
Great question. I would say that in many ways, we have become so specialized on the disease or the modality that we forget the patient in some cases. And we should never forget the patient and what the patient can tell us about what's going on. So, yeah, I do think that having multidisciplinary conferences are really important, and I think very helpful in getting different input from different um, um, angles, if you will, because I think that actually the more differences you get, and understanding that probably the more backgrounds, I should say, that you get, the more likely you're going to end up with the solution that's best for that given patient. I do think that we, if we stay in our silos, that's a problem. If we just use their silos to dig deeper and then come out and talk with everybody and don't leave it siloed, but bring it back to the group, I think that can be really important.
Right. Makes perfect sense. Well, that actually is a great segue into our next topic, AI and machine learning,
Yeah.
because a lot of folks do believe that AI can help break the silos and help us understand patients in a more holistic way, that where we can gather data from various aspects of the patient that may not be readily available to us through more conventional means. Can you tell us a little bit about how you incorporate AI in your work, and how do you see the world of AI and machine learning in biomedicine, especially cancer research, evolving? Where do you think are the low-hanging fruits?
So I think there's really two different areas that AI can help with. Number one is drug discovery, and really helping out with that. And I am not as involved in that area, but clearly I see the utility there. And also clinical trials in general. So this could be the development of the clinical trial, the whole preclinical through to clinical trial completion process. So helping generate the actual protocol all the way through helping out with referrals. That we can. There's so many different aspects I could get into there, but also AI embedded into the clinical trial itself, so that maybe wearables or other things could be used that give us more information about the patient that is just using the ubiquitous wearables that we all have, the smart wearables that have this digital exhaust that nobody's capturing and using. But could this be helpful for understanding the impact of that therapy on the patient, either in terms of toxicity or in terms of actually better physical function, because the therapy is working and they're feeling better and they're up and about more. It's hard to get that in a busy clinical practice from discussing with the patient versus a more um, data that you can get that's easily quantifiable from
Right.
these digital devices.
Yeah, absolutely. Atul Gawande, who's a very well-known surgeon and writer, I remember in a New England Journal of Medicine article, he wrote that the more we know, the less we cut. And I've been sort of thinking about that in the context of computation, and the fact that the more we can measure, the more we can compute. For example, today we don't have a very quantifiable, objective way of measuring something as simple as pain, or a patient's affect, or mood. And Dr. Gerd, you've done very interesting pioneering work in that domain, going back to several years ago when AI was not yet mainstream. And you also mentioned biosensors. Can you tell us about the portfolio of research that you've been advancing in those areas?
Yeah, absolutely. So, first of all, let me talk a little bit about our trial that we're really looking at facial recognition for pain estimation, and we're are basically doing a couple of things. So, we're taking a video of the patient, and and then we're having them read or talk, and they're going in and doing this pain inventory, which is this standardized test to say what their level of pain is, and then we're correlating their facial features with that. Now we're doing this in a variety of different skin tones and a variety of male and female and young and old. We're done this in adolescents, and and then we're doing it in patients that have severe pain, mild pain, moderate pain, and also all the way down to no pain. So what we're learning though is that we can use machine learning to understand what's going on in the face to be able to recognize the level of pain that they have. Now, just imagine with me. Just kind of don't worry about the regulatory implications right now, but imagine with me if 10 years from now, we had the ability to have this in the background on the person's phone or laptop computer. And somebody with advanced cancer is just typing away on their laptop, and you could tell that they're just starting to get a little bit of pain, that they're scrunching up their features. This potentially could recognize that, and using an implantable device could just deliver a very low dose of pain medication, maybe narcotic, maybe something else by that time, to just take the edge off of the cancer. That could really greatly help the quality of life of the patient, as well as decrease their utilization of healthcare. Turns out that 60 to 80% of patients with advanced cancer have pain crises. This often happens in the very end of life. And this really takes them away from their loved ones, leaves them in the ER for extended periods of time, and is inefficient and ineffective. If we could go earlier on, we could nip the pain issues in the bud, and you need much less pain medication to handle low levels of pain than you do if you wait until it becomes pain crisis.
You've also been looking at voice, audio waves.
Yeah.
I always think about how many times I have been able to pick up brain metastasis by just talking to the patient on the phone, having noticed a flat affect, or they're just not themselves. It's very hard to quantify, and I guess that's what they call clinical judgment and intuition, which is dependent on so many different factors: experience, how tired one may be, if there's a good cell phone reception, for example. There's many extrinsic and intrinsic factors that can interfere with that. So it seems like we may have an opportunity to use AI to essentially democratize those skills and make them much more objective and quantifiable. Can you talk a little about using voice recognition to extract actionable insights?
Absolutely. So the same study, because we're getting video, we're also and when we're in clinic, we actually get an infrared video too, which can have additional implications.
Right.
The idea really is to be able to use this to integrate with the visual data to come up with what really is severe pain, what is moderate pain, minor pain. There are so many different there are so many different auditory clues that one can get from a person's voice that are really important. I think that this is one of the largest data sets of visual and auditory clues that are annotated with level of pain, and has the entire spectrum of what one could get with in terms of uh, the male versus female gender and the skin tone, because that can affect the visual cues too. So I think this is going to be a data set that others are going to be able to use. And we hope to have our paper coming out on that in the near future.
Oh, that's amazing. So you're going to be open sourcing the data set.
We are.
Oh, well, we'll be looking out for that. That's fantastic. Hopefully, we'll very soon get very close to replacing the 11-point pain scale, happy that face, and have something much more objective and quantifiable that can help patients. As you said, pain is something that's cumulative, and once it goes above a certain threshold, it's very hard to manage. And this can really be helpful in improving the quality of life of patients with cancer and other chronic disease conditions that are associated with chronic pain. This is great, Dr. Gulley. I believe we can talk for another hour. Time goes by fast when you're having fun, they say, and we're almost out of time. I'd like to end with a final question. What excites you today about cancer research, and what worries you?
So I think the thing that excites me about cancer research are the opportunities. I think that immuno-oncology, as I mentioned before, has the best chance of providing cure. I think that opportunities also in early diagnosis and even prevention are going to be really important. And I think that immunotherapy and the immune system may play an important role there. I think that there are also opportunities to make the clinical trials process more efficient and more effective. I think that if we can use large language models and generative AI to help us in the clinical trial infrastructure to make things more efficient, um, right now we are taking things from the electronic healthcare record and we are manually entering them into the electronic case report form.
Hmm.
These are both electronic systems. There should be a much better ability to do this from an IT's perspective. Some of the data is going to be easy to do, like structured data, but unstructured data like progression-free survival, that's going to be more difficult. But in my mind, that's not a matter of if it will happen, but when it will happen and how. And we're, I think, working on that very closely. We're likely going to have something in the next few years that will be helpful for folks. In terms of challenges, see that there are several challenges. Number one, we have the biology of the cancer, and that is always going to be a challenge to understand the complexity, the complex interplay between the biology of the cancer and the host, including the immune system, and how the agent that is being used interplays with that. I think other challenges include how can we intervene earlier on when the cancer is easier to crush, and then what types of treatment are going to be there. I think on the infrastructure side, we also have the challenge of funding in the current environment and what that could look like. Um, I think that in this current environment, it is going to be important to focus on opportunities that are going to be game changing and going to not just be incremental advances, but be big, bold things that perhaps you're going to need a group of people to come together. I think there may be other funding models that are out there too that could be leveraged, including philanthropy, which has been historically always good. But I think that there are perhaps even more opportunities now, as well as working with industry, and that could be either in-kind support or it could actually be monetary support.
Sure. Well, it seems like despite the challenges, there are multiple opportunities ahead, and this might be one of the most exciting times to be doing cancer research.
Absolutely.
Dr. Gulley, thank you for your time. This was a great conversation.
Thank you, Sean. Take care.